Hey podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center, New York Medical College, and I'm your host for the Neurocritical Care Society podcast. Let's start with a hypothetical scenario. You accept a patient to your neurocritical care service with a 65cc basal ganglia bleed. Their glycemic scale is 8, and their systolic blood pressure is 190. What systolic blood pressure goal would you target? Now, let's change the scenario a little bit and say the ICH volume is 25 and the admission systolic blood pressure is 220. What's your target now? Now, despite multiple attempts to study and standardize care, treatment practices vary across the globe, and probably even amongst practitioners within the same health institution. The two largest randomized controlled trials examining optimal blood pressure control after ICH, the ATACT-2 trial and the INTERACT-2 trial, examined small to moderate-sized hematomas, leaving those with large and even more severe hemorrhages an understudied population. While acute blood pressure lowering from 220 to 200 millimeter mercury may be beneficial, there's limited evidence that targeting one blanket blood pressure target is broadly advantageous. Furthermore, the interaction between the speed by which you reach that goal and how long to keep the patient there and how that affects outcome is truly unknown. This ultimately hinders our efforts to personalize our patients' care, since attempting to identify patients that are likely to benefit remains arbitrary. Today, Jason Siegel will be interviewing Dr. Afshin Divani on behalf of the co-authors of their article entitled "The Magnitude of Blood Pressure Reduction Predicts Poor In-Hospital Outcomes in Acute Intracerebral Hemorrhage" that was published in the Neurocritical Care Journal last October 2020. I hope you enjoy this episode.
Hi, I'm Jason Siegel. I'm an assistant professor of neurology and a neurointensivist at Mayo Clinic in Jacksonville, Florida. And I'm a member of the NCS podcast series committee. Today it is my pleasure to have Dr. Afshin Divani. Dr. Divani received his bachelor degree from Youngstown State in Ohio and his master and doctorate degree from the State University of New York at Buffalo. He has completed a research fellowship in sleep disorder at the Pulmonary and Critical Care Division of Department of Medicine at SUNY at Buffalo. He has also completed a stroke research fellowship at the Department of Neurology and Neurosciences at the New Jersey Medical School, Rutgers University. Dr. Divani is currently an associate professor in the Department of Neurology at the University of New Mexico. Prior to that, he was an assistant professor of neurology and neurosurgery at University of Minnesota, where he also served as the director of stroke research at that institution. Dr. Divani has been a primary or co-investigator on different funded projects by the National Institute of Health, American Heart Association, and private industry. He is a fellow of the American Heart Association and served as a member of the research committees. Today, we're going to be talking about the role of blood pressure management in patients with intracerebral hemorrhage. In particular, we're going to be discussing his paper, "The Magnitude of Blood Pressure Reduction Predicts Poor In-Hospital Outcome in Acute Intracerebral Hemorrhage," which was published in Neurocritical Care in 2020. Dr. Divani, thank you so much for joining us today.
Thank you so much, Dr. Siegel, for the opportunity. It's an honor to have this opportunity to discuss our recent publication.
So, blood pressure management has been a staple of intracerebral hemorrhage care for some time with few other treatment options. What do we know about blood pressure management in ICH, and what gaps does this study aim to fill?
It's a very good question, and if I allow to spend 40 seconds on the historical context of blood pressure management, probably help the audience to understand a little bit better what was our aim and why we did what we did in terms of the study. As you may know, back in 70s and 80s, there were two discussions when it came to intracerebral hemorrhage. One, does hematoma expansion happens, which many thought there was no such expansion since at the time CT scans were not, or scanners were not necessarily readily available. And patients came late to the hospital or the scan was done very late. So more or less, we were not witnessing the expansion and scanning the basically brain after it was done. The other question, which was lingered for several years up to early 90s, was, does perihematoma ischemia occurs? And if it does, do we need to increase blood pressure to avoid it, basically to avoid ischemia? Well, in early 90s, CT scanners became available, as I mentioned, and more ICH patients basically came to the hospital soon enough after the onset of ICH, and they were scanned with follow-up scans at different time points. And that gave us the opportunity to learn that, yes, hematoma expansion does occur, which is about 30%, 1/3 of the patient or less. And most of the expansion happens within the first 24 hours, and mostly within the first 3 or 6 hours, the majority of the expansion is done. Therefore, the issue of this hematoma expansion to be or not to be was settled. Now we know it does happen, and we know now that hematoma expansion contribute to worsen outcome. Patients do much worse when we observe those expansions. Around the same time, a lot of preclinical studies looking at the metabolic activities of perihematoma regions revealed a hibernation condition that prevents ischemia. So basically the concern that perihematoma ischemia is a problem that we need to increase the blood pressure to avoid it was kind of resolved. So kind of led us to come to the point that reducing blood pressure to prevent hematoma expansion was safe. However, one has to keep in mind that at the time, those animal studies did not include animals with pre-morbid conditions, with chronic hypertension, or looking at different hematoma volume. We had to induce hematoma volume, hematoma in the brain by whether injecting the blood or using clogeness to basically break up the capillaries to let the bleeding happen. But in terms of different sizes at that time was not considered. However, those studies led us to believe, yes, hematoma expansion does happen, and yes, you could reduce the blood pressure in a safe manner. That led to several clinical study phase 1 trials, such as FAST trial that factor 7 was basically used by Dr. Stefan Meyer at the time he was in Columbia University, and INTRACT study and ATAC, which the two last studies or trials focus on reducing the blood pressure. So the concept is you have a leaking pipe, and by reducing the pressure, you reduce the leaking or stop the continuation of the leaking, thereby preventing hematoma expansion. However, recent phase 3 trials, such as ATAC2 and INTRACT2, failed to show the benefit of aggressive blood pressure reduction in improving the outcome. And after spending millions of dollars, and each trial lasted more than 5 years, so basically we kind of went back to square one. However, that gives us an understanding that maybe the idea of a fixed target blood pressure level for everyone need to be revisited, that we cannot basically reduce every patient blood pressure to a fixed target level. And because of that, obviously after INTRACT2, the latest guideline for treatment of intracerebral hemorrhage that was published in 2015, which Dr. Hamfield and Dr. Anderson, who are a co-author on the paper we published, were part of the investigator who published the guideline, recommended the blood pressure should come down to below 140 millimeter of mercury for systolic blood pressure. But this guideline continually, basically looking at the management of blood pressure based on a recommendation of a single fixed target value for all ICH patients. And based on INTRACT, again, for blood pressure between 150 to 220 millimeter of mercury, the recommendation is to reduce it below 140. They also made the recommendation that it might be okay for more than 220 millimeter of mercury to reduce it is reasonable, but we really don't have a good, strong evidence when it comes to a clinical trial that focus on that cohort of patients with much larger initial blood pressure. And this is the same problem for several other guidelines when it comes to, for example, treatment of aneurysm or IVTPA for large vessel occlusion, they all based on a single target level. However, several years ago, I did most of my PhD on AVM embolization, and I learned back then, when you have a large AVM with several feeding pedicles and several draining veins, when it comes to embolization, the physician would not embolize all the feeding pedicles in one session. Intuitively makes sense. You want to avoid the still phenomena. The brain doesn't get the blood flow that needs it. So if you block these pedicles in the nidus of AVM, you would restore the normal physiological flow. However, doing so in a rapid manner after the brain has got used to a suboptimum blood flow condition for several years was detrimental. So the physician would basically do it stepwise to occlude or embolize some of the pedicles, bring the patient back several days later to occlude the rest. Same thing kind of bothered me for a while, that are you telling me a patient comes with blood pressure of 20/20 or 20/30 or 200 millimeter of mercury, and a patient comes with 150 and you reduce both of them to 140, are they really going to respond the same? And that was a little bit kind of didn't make sense intuitively to me, because the body, for whatever reason, has got used to that suboptimal condition, in this case, hypertensive condition. So this is what we try to basically address by performing this study, that rather than looking at the target blood pressure, which was conducted in this clinical trial, look at the effect of blood pressure reduction vis-a-vis initial blood pressure and initial hematoma volume.
I think you did a fantastic job illustrating that even though we're looking at a seemingly homogeneous group of patients, it's very hard to apply a one-size-fits-all treatment model to them. And when we think about studies and their generalizability of them, can you describe the patient population that you guys targeted and why you chose these patients?
That's a very good point. Again, most of these clinical studies that have led to developing the current guidelines are based on best case scenario or very polished kind of situation. They didn't recruit patients with large hematoma. They did not recruit patients with infratentorial hemorrhage or so many other conditions. However, in real life scenario, and neurointensivists deal with all kind of ICH when they come to the hospital. So you cannot say, oh, the blood pressure reduction was basically appropriate for this cohort, but we don't know what to do for the other cohort. So we thought, let's recruit, this was a retrospective study, obviously, but we included all the patients who came with ICH as a spontaneous ICH, obviously. The only thing we exclude patients that they had bleeding due to secondary factors like trauma, arteriovenous malformation, rupture, or whatnot. Otherwise, we basically took every patient that available from January 1st, 2008 till end of 2017. So we have a 10-year admission of two healthcare systems in Minnesota, University of Minnesota and Hennepin County healthcare system. We basically recruit every patient regardless of their initial hematoma volume, regardless of their location, regardless of initial blood pressure and whatnot. And that gives us a better understanding the real life scenario, what are we dealing with and how this blood pressure management should be handled.
Thank you. Yeah, and I think that does help, as you say, kind of fill some of those gaps in those previous studies. Can you give us a little bit more about your overall statistical methodology for this study?
First, I have to make a disclosure. I'm not a statistician. I'm a cheerleader when it comes to statistical analysis. But we were fortunate enough to have fantastic statisticians on board. One of them, Dr. Alex Pedersen, who did this fantastic modeling. And he was one of the pioneers actually for using this analysis for other studies. And we reached out to him. We did similar method for looking at hematoma size to predict the outcome with just looking at the characteristic of hematoma. We published a paper a year prior to this, using the same data set basically, and we found interesting stuff by using the method that we also use in this paper. So basically the statistical analysis focused on the effect of systolic blood pressure reading over the first 24 hours on various outcomes. The primary outcome being ordinal modified ranking scale score categorized by or as good between 0 to 2, poor 3 to 4, and severe 5 to 6. Due to the longitudinal nature of systolic blood pressure readings and variability in number of recording across subjects in this study, again, this is a retrospective study. Not every patient blood pressure was recorded in a very continuous and organized fashion. There were some missing recording that we had to deal with. So because of this unsupervised functional principal component analysis was used to reduce the collection of reading to a few interpretable SP or systolic blood pressure features that altogether explain about 97% of overall variability in systolic blood pressure reading. Basically, the functional principal component analysis creates some eigenfunction or proper function. Eigen is the German name for it. And you try to correlate those functions or variability that are described by those functions with different feature of systolic blood pressure. And if there is a high correlation, you assume this function represent that basically characteristic of the blood pressure, which we did it in this case. So the focal systolic blood pressure feature was reduction, which because this was unsupervised, we let the data basically tell us what we see rather than what we wanted to see. So we realized within 6 hours, compared to the baseline reading and admission, there were a lot of variation. Within that 24 hours, the first 6 hours was very significant. So analysis of variance was used to assess basically the difference between systolic blood pressure reduction across initial hematoma volume and initial blood pressure strata. And this is the difference compared to ATAC or INTRAC studies, that we did not blindly look at the blood pressure reduction. We basically considered the initial hematoma volume and initial blood pressure values. And permutation tests assess the hypothesis of increasing systolic blood pressure reduction, or what we call a delta blood pressure, the difference between your initial and whatever you're going to end up within 24 hours or 6 hours, basically by hypertension studies. We also look at the history of hypertension among these patients that previous studies have not looked at it, such as normotensive, treated hypertension, or untreated hypertension cases. We basically kept a record of those as well. A secondary analysis of systolic blood pressure reduction assess interactive effect of systolic blood pressure reduction with both initial systolic blood pressure and initial hematoma volume on the risk of basically adverse outcomes. Finally, multivariable logistic regression models assess the significance of systolic blood pressure reduction on the risk of adverse outcome while controlling for other clinical features, such as, for example, intraventricular hemorrhage, initial Glasgow-Coma scale, and whatnot. And also imaging characteristic, hematoma shape, regular, irregular, and whatnot, where these additional independent variables were chosen using a Bayesian basically information criteria. Systolic blood pressure reduction was first treated as a continuous variable, and in subsequent analysis as a categorical variable. So give it a more clinical perspective that we're not worried about every single millimeter of mercury changes, look at it in terms of 10 millimeter epoch per se, to make it more meaningful. So basically, the formal analysis was used to quantify the effect of incremental changes in systolic blood pressure reduction, versus the later analysis was used to determine possible cutoffs for systolic blood pressure reduction above which the risk of an adverse event is significantly increased. That's a very short, again, Don't ask me how we did it. We had
I appreciated the explanation of the unsupervised functional principal components analysis, because that was a term I had never used before. It's a mouthful, and I think something I took from this the study is that you guys appear to be as comprehensive as you could in describing these patients. Again, trying to hit that point that you made, that they're not all the same, and to figure out the factors that truly make them different. Tell us, what were the major findings of the study? Obviously, you did a lot of different analysis, but can you share with us the major findings?
Sure. The major findings, interesting, in multivariate logistic regression models. We saw a 10 millimeter increase in systolic blood pressure reduction, meaning 10 millimeter for delta pressure, what we call it, or additional decrease in systolic blood pressure compared to baseline, was significantly associated with worse, which we define it as MRS more than 2, worse outcomes, when treated systolic blood pressure as a continuous variable. When we treat it as a continuous variable, that's what we observe. We categorize systolic blood pressure reduction, those with systolic blood pressure reduction between 40 to 60 millimeter of mercury and above 60 millimeter of mercury had significantly higher probability of worse outcomes, again, meaning modified Rankin scale more than 2, when compared with those systolic blood pressure below 20 millimeter of mercury. In an exploratory fashion, the models that assess interaction between systolic blood pressure reduction and initial hematoma volume and initial systolic blood pressure revealed 2 interesting findings that basically could be subject to follow-up studies. First, in a small and medium-sized hematomas for initial, which again, the analysis shows we didn't have a predefined what is the size of hematoma. For a small, we found below about 7.5 millimeter ml or cc, and for medium size, we found something between 7.5 to 30 ml. An interesting ICH score defined hematoma volume more than 30 as affecting, negatively on outcome. So at least we had something to compare. Obviously, I talked to a lot of our co-authors at the time that, do we have any information about what is a small hematoma volume that may, lead to a better outcome? Nobody had this information, but we had for the upper limit, which was, we found 30.47 ml, but 30 ml is already established as for the ICH score. Lower values of systolic blood pressure reduction were associated with higher probability of good outcome. Again, MRS between 0 to 2 as we defined it. So that was the first finding. Second, for large hematomas, which they were more than 30.5 ml or 30 to round it up, although the good outcome was very unlikely. We know when patient come with a large initial hematoma volume, that the outcome is not that promising or hopeful. Although it was very unlikely to have a good outcome, lower level of systolic blood pressure reduction was associated with a decreased probability of severe, which in our case was MRS 5 to 6 outcome, in favor of poor 3 to 4 outcome. So basically, even though in general the outcome for large hematoma volume was not good, lower level of systolic blood pressure reduction still decreased the probability of severe among the same cohort with large hematoma.
And I think that's a very interesting point. I think when the very large hematomas come in, sometimes there's even an urge to, we really got breathing this blood pressure down as much and as fast as we can. Look how big this hematoma is. But what you guys are reporting is that maybe that could potentially be harmful for the patient. And that I think in many ways could be practice changing, or at least enlightening for many people out there. Can you give the listeners 1 or 2 high yield take home points, maybe even something that they could try to incorporate into their practice based on your findings?
Basically, looking at the initial hematoma volume and initial blood pressure, And that's what hopefully with subsequent studies or future studies, we can come up with a better table per se to look at it, that especially for what you mentioned about large hematoma volume, the outcome is worse. And I think that intuitively makes sense. When the hematoma is extremely large, the ICP obviously is higher. So reducing blood pressure quite a bit could be detrimental for those patients, for example. So it's extremely, the take-home message is we need to look at what patient comes with when it comes to, in terms of hematoma volume, initial value, and what is their initial systolic blood pressure. And you cannot reduce substantially a large, or high systolic blood pressure in order to achieve a good outcome. So hematoma volume and initial hematoma volume and initial systolic blood pressure basically have to be looked at when we're planning our blood pressure management for ICH patients.
Last question. What can we be looking forward to from you in the future in this topic?
Again, I wish I had 48 hours a day and then all the money in the bank. There are several ideas. But what we like to do is to have a well-designed prospective study targeting systolic blood pressure level, systolic blood pressure variability. Prior to this study, we published also a paper that other people, including Interact 2 group, published a paper that systolic blood pressure variability or high variability lead to worse outcome. So we would like to do a study that looking at the systolic blood pressure level, the variability of systolic blood pressure, the magnitude of the reduction, and all of this vis-a-vis initial hematoma volume, to be able to answer the following questions. One, do untreated hypertensive cases have a worse outcome versus treated or normotensive cases? Does untreated hypertension lead to higher blood pressure variability? From what I've seen from our data, we have to do a specific analysis. It seems like untreated hypertension cases have higher variability. They're not used to being controlled per se. The blood pressure doesn't like it. If you haven't controlled it before, now all of a sudden you come and tell the blood pressure, I want you to go to this level, way below what you are or have been for so long. So basically, we see a larger variability for untreated hypertension cases. So we want to see if that's a real case or not. And basically, have a customized blood pressure reduction study using a multi-parametric mode for assessing blood pressure variability during acute phase, evaluating ICH volume and cerebral perfusion. Again, I think this is quite a bit missing in a lot of our trials or studies, that we need to consider cerebral perfusion with respect to other regulation also. And cerebral perfusion pressure as a single parameter probably doesn't provide the whole picture. I think it's very important when we're looking at the cerebral perfusion pressure, we should also look at ICP or MAP. And I can give you one example. An example would be, for example, if the MAP is 120 and ICP is 20, your CPP is 100 millimeter of mercury. However, if MAP is 150 and ICP is 50, you still have a CPP of 100 millimeter of mercury. So just looking at CPP without considering one of the other parameters, I don't think we are looking at the proper picture. The stress the brain going to take for a higher value, even though you have similar CPP value, needs to be considered. That's why I think it's very important to look at, when we look at the cerebral perfusion pressure, we also look at MAP or ICP.
I think it's a great point, and illustrating further, the one size fits all, it does not necessarily work with these patients. Thank you so much, Dr. Divani, for spending time with us today, for educating our listeners. Thank you, everybody, for listening. Please continue to check out our podcast with a lot of upcoming and great topics. Dr. Divani, thanks again. Any parting words you'd like to share?
I appreciate the opportunity. It was great that Neurological Critical Care Society showed interest, and that's promising to us to continue. And hopefully we can with all this study, have a better idea of how to deal with ICH patients, because as you know, we really, when it comes to treating those patients, we kind of very powerless. We still don't have the magic bullets or very effective treatment. And I hope these studies will lead to something that gives us a better understanding of how to treat these patients. And thank you so much again for the opportunity.
Thank you so much again.
Now in its fourth version, the Emergency Neurological Life Support Certification course focuses on improving care during the critical first hours of patients with acute neurological emergencies. ENLS demonstrates a collaborative, multidisciplinary approach and provides a consistent set of protocols, practical checklists, decision points, and suggested communication to use during patient management. The ENLS course is designed and accessible for all practices, from physicians to residents and everyone in between. The course can be taken exclusively online, or you can attend a live instructor-led course in your area or at a conference before completing the online certification. To learn more about ENLS certification, please visit www.enls.neurocriticalcare.org and use promo code PODCAST for an extra 10% off your purchase.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threkold, Teddy Yoon, and Chris Zamet. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.